Hello, everyone. Thank you very much for joining today. It's my pleasure to introduce Michael Strom. Michael is an international recognized leader in shockwave therapy and men's health. Michael's based in Copenhagen, and he specializes in treating conditions such as erectile dysfunction, Peyronie's disease, chronic health pain, chronic pelvic pain, and is known for pushing the boundaries in how focused shockwave is applied within clinical practice. As a respected clinician, educator, and global speaker, Michael also brings a highly practical, evidence-based approach, helping clinicians to achieve better outcomes through smarter use of the technology. Today, he'll be sharing how focused shockwave can help elevate your approach within the clinic to men's health. So if anyone has any questions throughout the session, feel free to pop them into the chat on the webinar, and Michael will happily answer them at the end. But Michael, I'll hand it across to you. Thank you. Sorry, Michael, you just have to unmute. Michael, you're muted, sorry.
Okay, then it should be good. I am Michael and I am the penis guy. I work in Copenhagen and I have my clinic where I only focus on men's health with shockwave, magnetics, sexology, so we can do a 360 around the clients. And that's really important because it's not just about the shockwave. As Siva said, I'm teaching for Elevation. I also teach for other companies, just to be clear about that. Been doing shockwave for about 10 years now. And as I said, the only thing I do is men's health. What we're going to do today is talk about piezoelectric shockwave, erectile dysfunction, Peyronie's disease, and chronic pelvic pain syndrome. So that will be the order, and I'll try to mix everything together in the end. This is my clinic. So I work with 4 different devices. I test different things. I do combinations. I don't believe that we should work with just a one device approach. In general, we need to have it as a part of a toolbox. It's very important that it's not going to be that magic bullet that if you don't have the device, then you can't do anything. You still need to remember where you come from, the general health of the client. That is extremely important if you want to have success. So in general, with Shockwave, we have 3 types of motor generation. We have the electrohydraulic, we have the electromagnetic, and the piezoelectric principle. Today, I'm only going to talk about the piezoelectric principle to keep it simple, but also to make sure we stay within the 1 hour. When we see the technologies, we have a lot of nice boxes. We have a lot of different devices. There's a lot of competition in the market. And I'm a clinician. I work for different companies, but I just talk about the facts. So when you're looking for a device, compare everything, look into the data, and then take your decision. But we're going to talk about the Elevation medical device by Wolf today. General for Shockwave, if you don't know it, we have a mechanical input of energy that is triggering biological responses. So we have the release of a vast majority of growth factors that can affect the tissue. So if you want to keep it simple, you have improved blood supply, you have modulation of inflammation. Before we said it was pro-inflammatory, but we're talking about modulation of inflammation. That is especially important when we talk about Peyronie's disease. But also the improved blood supply is very important for the erectile dysfunction. In the end, all these factors is leading to tissue regeneration. You already know that for tendons, for muscles, for bone, but we can also do it in the pelvic floor, for penis, but also for vagina, for female health. So this is a simple way to put it up. If we want to make it a bit more advanced, there's a great study that reviews all the clinical factors from Greece in Shockwave for erectile dysfunction. So this is a very nice figure. This is one of my favorite figures to explain how Shockwave is actually working. So if we just divide it, we work with the blood vessels, we work with the corpus cavernosa. So in general, we have the release of a nitric oxide, we have the release of different growth factors, we have smooth muscles that's affected. We downregulate collagen and trans growth factor beta 1. That is a big part of the Peyronie's disease. And that is also where the research is going right now. We're not looking in specific protocols. We're looking at how can we affect the main biology changes. So these things are leading to basically better microcirculation, but also remodeling of the tissue and restoring elasticity. And elasticity is also what you see in the skin, but it's really important for the penis because if you want to have a correction, the corpus callosum, all the cells need to be able to expand 20 to 25 times. So that's really important that that works. If we continue, we also have the release of stem cell effects. We have the increased cell survival, tissue repair. So if we reduce the inflammation and oxidative stress, we have a better local environment. And that is really, really important when we talk about erectile dysfunction and we talk about Peyronie's disease. The most important thing that I believe we should be looking more into with research as well is the reinnervation of the nerves. We have seen studies in mice where they severed the sciatic nerve, made sure it didn't grow back together. They took out a 7 millimeter portion. They did shockwave, and there was actually a spontaneous regeneration. So if you look at the most difficult cases of radical prostatectomy, then we have a good option possibility to reinnervate the nerve and limit the damage after the surgery so we can keep the erection and the continence situation. When we have a focal shockwave, we have a very steep increase in pressure of the sound wave. And this graph is just displaying that the red one is a shockwave, it's electrohydraulic. And then we have the radial pressure wave that doesn't go to the same pressure. So you cannot compare these two technologies. That's very important to remember. So when we have a focal shockwave, we have this very steep increase that is creating that biological effect. You cannot compare it with ultrasound, and especially with ultrasound compared to a piezo device, because it's still piezo crystal. It's two different ways to work. So we have this very steep increase of pressure created by these piezo crystals that just gonna focus very precise into a specific depth of the tissue. And we need to discuss if it's a single layer and a double layer. That is one of the things you need to be very aware of because there's coming a lot of devices today. And what Elevation Medical did a few years ago was coming with the double layer technology. So basically they created a more powerful machine so we can get a more intense focal shockwave. So when you look at it, there's the single layer, there's a double layer. One of my favorite applicators is a double layer because I want that very specific high energy when I work, especially with Peyronie's disease. One of the myths I always hear is that piezoelectric shockwave is very superficial, but that is a marketing thing because most people forget that there's actually 5 applicators. We have the 4-point focal applicators, and it doesn't matter with the names right now, but just remember that if you know what you want to work with of specific conditions, then you can get the therapy source, the handpiece, whatever you call it, that will fit that description. So in my setup, I have the G4, the G6, and I have the linear 5G2. What is really interesting with this combination is that I can go fairly deep, I can go superficial, and I can go very wide with a high amount of energy. So the linear probe that you see on the right, that is specifically tailored for erectile dysfunction. But one of the other things where it is really, really interesting is for Peyronie's disease with calcified plaque in the tunica. But we're going to go back to that in a bit. What I also really like with the piezoelectric system is that there is full transparency about energy, depth, and the size of the focal zone. So here you can see that depending on the specific applicator, you can go from 0.16 to basically 0.28 millijoule per square millimeter. So we can go really, really high and intense in both superficial and very deep part. So piezoelectric shockwave is not as simple as everyone is talking about. We have a lot of good options. And if you combine it with ultrasound, then you can be extremely precise and work in a way where it doesn't feel very intense for the clients because you're not hitting a lot of tissue next to it. You're hitting the right spot that you need to. And that is especially important in Peyronie's disease. So when we look at the linear system, that's a double layer piezo system, and you actually gonna have energy that is 2 centimeters in the depth, 2 centimeters in the width, and 46 millimeter of length. So that is like a good thump where you just put down energy into the penis. So in that way, you can hit both corpus cavernosums in the same time when you work it from the top side. You don't have energy going into the urethra. You can be very specific and you can save some time. This is also good if you're working with tendons in general. For Achilles tendons, I love this device. One of the things that I just said is that compared to a point focal device, then you're going to hit more tissue at the same time. And that matters if you want to have a good treatment, but also if you want to make sure that you get the energy distributed in all the corpus callosum during the treatment. So again, both concept is working, but there is some advantage to work with a linear system. Remember that if you see linear systems in general, because there's coming a lot of different devices, some of them will only be a single layer and not as powerful, so you cannot compare one-to-one with other devices. Let's move into the erectile dysfunction. When we look at ED in general, 50% of men over 50 will have some kind of erectile dysfunction. It doesn't need to be, I can't get the erection at all. It can be, it's slightly difficult to maintain it, to complete the intercourse. It can be difficult to get the erection. It can be difficult to penetrate. But also 10% will have complete absence of erection. And that is where we need to be very careful that we don't overpromise what we can do with Shockwave. Another interesting fact is that when we look at the use of PD5 inhibitors, the Viagra, the blue pills, the Cialis, that's a yellow pill, then the market will grow from 22 to 32 with almost 7%. So that means that in 2032, we're going to spend 6.1 billion US bucks on the most popular blue pills. That just show that there's a good options for Shockwave in the clinics for the next many years ahead. We also see growth in the GLP-1, the Wegovy, the Ozempic, the different weight management drugs. People getting more and more obese, not just in Europe, in US, but globally. So more sedentary lifestyle will increase the rate of erectile dysfunction for most of the people. Then we can say, why is this that important today? But in today's society, maybe not the last few years, in general, all our psychology needs, our safety needs, love and belonging, they are fulfilled. We're not lacking of employment. We have food on the table every day. We have personal security. So sex is becoming more and more important. It's about your self-esteem. It's about self-actualization, the best version of yourself. So that's also why we see more and more young people is having issues with sexual dysfunctions. When I started working with this in 2016 and 17, I was like, okay, this is going to be the older population. It's going to be the 50s, the 60s, the 70s. But I also see clients in the 20s. I have clients in the 20s this week. But it's also because it's very important. And maybe it's because of the social media that everything needs to be perfect. And if you look at this graph from McKinsey, then you can see that Generation Z and millennials, they have a higher focus on managing stress and anxiety, sex and health, skin and hair care compared to previous generations. So we also see an aesthetics that is really booming ahead. So that's also why we have an option for our concepts. When we look at the European Association of Urology guidelines from this year, it's you can see that Shockwave with or without PD5, the blue pill for vasculogenic ED is an option. This has been as this since 2023. So if you look at their way of working, of course, we need to do a good diagnostic. We're not going to dive into that today, but we need to see, can we actually help the client? They can do the vacuum devices, the PD5, injections. We can do the Shockwave. In the yellow box, they talk about the patients with definitely severe AED. That could be nerve sparing operations where there has been an injury to the nerve. With the look into basic research, maybe Shockwave can be a part of that as well. I see really good results with that. So why not give it a shot? Basic anatomy, we have the corpus callosum. They are important to get direction. We have the tunica, the Bell's fascia. That is very important when we talk about Peyronie's disease. We have the arteries, the vein, the nerves. This is a basic anatomy you need to learn if you want to work in this area. We also have the nerves. A lot of people is forgetting about that, and that's where I think that if you want to have a really good protocol for your ED treatment, you're gonna work more than just around the penis. You're gonna work around the spine as well, especially around the pudendal nerve. That is a big cause for pain, but also sexual function. When we look at the good and bad things for erection, this is from a Danish study where they looked into how you can reduce the risk of a cardiovascular disease. If you do physical activity, exercise, have a good balance in insulin, testosterone, normal weight, not as obese, then you'll have a good erection. The bad thing is reduced nitric oxide. That can be caused by sedentary lifestyle, obesity, inflammation, hypertension, metabolic syndrome, atherosclerosis, cardiovascular disease. These things are the first thing you need to identify in the first session. And the study also shows that, or if you look at this, the smoking, that will reduce the release of nitric oxide, that will bind it. So if you have someone above 50 that's been smoking for many years, they have severe AD, it actually doesn't matter for them to stop smoking. If they're below, it will make a difference. But in the end, you should make them exercise. So the study from before shows that if you do 4 times 40 minutes a week with moderate to high intensity, then you can actually reduce the risk of cardiovascular disease and ED with 10 to 15%. So that is a quite small investment compared to what people are going to pay for having the shockwave treatment. When you do the first assessments, of course, you need to go 360. Are there any underlying diseases, comorbidities? You're going to see if there's any deformities. Are there any Peyronie's disease, anything neurological or cardiovascular? You're going to do a blood test. If you don't do these things yourself, then make sure the doctor will make a full blood panel to see if there's anything out of the ordinary. The easy thing for you is to do the International Index of Erectile Function. That is a 15-question questionnaire that's going around the most important things. So the first question is about the function in the penis. We have something about the orgasmic function, satisfaction, basically the sexual desire that can potentially lead into testosterone. What is the relationship indicators? And then you'll be scored into 5 degrees. And to be honest, if you have severe degree, that can be difficult for Shockwave if you look at standard protocols. Then you need to see the protocol as a guideline. I also have a patient that is scoring 26 to 30, and I had one guy scoring 28. He still wanted to have 6 sessions because he wants to be the best version of himself. So these groups are what you're going to look into. Where we see the best effect is from the mild to moderate. The moderate can also be elevated quite well with standard protocols and good lifestyle. The severe, that is where you're going to work with all the tool in your toolbox. It's not enough just to say we're going to do X amount of shockwave. They really need to get themselves together and change their lifestyle. Another thing that I think is important in erectile dysfunction is ultrasound. This study from Asia shows that you can correlate the blood flow, the peak systolic volume in the flaccid state in the penis and compare it to the IF5 test. So if you don't do a scan, you actually don't know what the tissue quality is. You can see some things that is not possible. So this is a blood flow of a young guy in the 20s. He's not having ED, but he has Peyronie's. But this is his flaccid state. So that's a really good blood flow. There's no problem with erection, only with Peyronie's. And one of the worst cases I've been having was a guy in the 60s. He's been having a penile implant some years ago. They had to take it out because of infection. They couldn't do anything with a new solution. So they're just like, okay, you're just going to live with it. So when we look at the structure on the penis, you can see the black lines going from top to bottom. That is where they did the scalpel and they destroyed the corpus cavernosum. When you look on the other side, you can see his blood flow is actually quite nice, but the structure is not capable of expanding and maintaining that erection. So in this case, if you just do the IF5 and you talk with him and he mentions, yeah, I had a penile implant, you'll say, yeah, okay, we can do this. But you actually can't. We gave him 12 sessions in total. He started to have better response to the PD5 again. So with a penis ring, he could have some erection that could be useful, but of course it wasn't satisfying. But a case like this, maybe you're going to do 20, 25, 30 sessions over a year in order to just get it to a point where you can use it in some way that the client would be happy. Another one is a case like this. You can see a small piece of plaque in the middle of the penis. you can see severe fibrotic changes in the one side of the corpus callosum, and actually on the other side, there's also a bit. So if you just take the questionnaire and say, okay, you have a severe ED, we're gonna do 12 sessions. 12 sessions is normally what we do for the severe degrees. Then you have a high risk of failing with this one. And with this guy, we've been doing 15 sessions. Yeah, he got his morning erections back, but there's still a lot of damage. So it can be difficult if you don't know what's going on inside. Let's start looking into this research. I know in physio, there's a lot of people using radial shockwave and saying, okay, we can just do that. That's a bit cheaper. This study compares radial shockwave training and a combination group. When you look at the radial shockwave, yeah, you're gonna have a short-term effect within the first 3 months, and then it's gonna go back to about baseline. If you do the physical exercise, you're gonna have a more long-lasting effect. If you do the combination, of course, that will be better because you're gonna change with the lifestyle. This is diabetics, so that is really important that they also make a change so they have a better local environment. But basically, if you choose between radial shockwave and physical activity, you're gonna have better results with physical activity. So instead of doing the radial, doing the focus, the physical activity, then you're gonna have some more long-lasting results. A study that came out in the US some years ago by Dr. Irvin Goldstein, a very skilled guy. He took a group of patients, did a sham controlled trial. No one had ever been having shockwave before, so he took a small Bluetooth loudspeaker, put between the legs, put the device on, so we were sure that they did absolutely placebo. He did ultrasound evaluation in the erected state to see how the tissue quality is. And then he did 6 treatments with a high amount of shots. And he could see a significant change in the homogeneity of tissue. So this was how he graded, but he could actually show that with the shockwave, we are remodeling the tissue. So we're gonna have a higher tissue quality and improving the erection. So that's really interesting. If we take it to this one, where we talk about Shockwave or PD5, the blue pill for young clients, that is below 40, even though they get a slightly better effect with the PD5, they prefer to have the Shockwave treatment because they don't need to plan. So you also need to look into that when we look at the sexual habits, then planning is not what people they want. So there's a small difference between the PD5 and the Shockwave group, but it's not a significant change. This study is also showing that when you look at the baseline, 6 weeks and 12 weeks, then on 6 weeks, the PD5 group will have better results compared to the Shockwave. But when we go to the 12 week, we actually gonna have better results in the shockwave group because we're remodeling the tissue. And this is also because that the effect we get from shockwave in general, the focus shockwave, is taking 8 to 12 weeks to complete. It takes some time to create these blood vessels, to remodel the tissue. So it's not something where your clients is gonna go from week to week and say, okay, now I can really feel it. No, you're gonna do an amount of sessions that will normally take 6 to 8 weeks, and then 6 to 8 weeks after they're gonna have the full effect. So this is also showing that shockwave is actually changing the tissue. It's changing the cause of the problem and not just treating the symptom. This one is also important to remember, and this is shockwave for diabetics. And these are one of the most difficult groups you can work with. This is just showing this mean change in the group. And we can see that up to a year, we have a significant change in the erectile function for these diabetic patients. What is really interesting is that the red bar is non-responders to PD5. We're actually turning a lot of the non-responders to responding to the blue pill again. And that's also a very important thing to remember when you start working with these clients. They're not gonna just go completely off the Viagra if they have a severe degree. The first point will be to get them responding to the PD5 again. And then we can talk about how we can move ahead. Another thing is that if we have the most severe degrees, after 6 months, the effect will start to decline. So maybe we're gonna do some maintenance because we can't cure the reason, the diabetes that is causing the erectile dysfunction. We also see it in radical prostatectomy cases. We have significant increase of the erectile function, the erectile hardness, and in general, a significant improvement when we start working with these patients quite close to the surgery. And the same with the Motil that also been working with the Wolf device. We see a change when we work with the Shockwave. One of the most interesting things is always when you talk with clients about how to set up the protocol. This one is a small sample size, but they do it right after the surgery, 1 to 2 weeks or 1 to 2 months. Different setups, very intense, then longer duration between sessions. And it just shows that if you work continuously with these cases, you're going to get the results. The interesting part here is that when you look at the first year after the surgery, you can see a big drop in the sexual function, the potency rate, and the intercourse rate. That is natural. They've been having a disease, they've been having surgery. The first year, they respond better with the PD5 inhibitors. But when we see on 12, 24, and 60 months, we can actually see that the one that's been getting the Shockwave is having higher potency rate and higher intercourse rate because we work with remodeling the tissue after the surgery. We're working with downregulating inflammation. We're working with collagen to reduce a significant high amount of scar tissue. So Shockwave right after surgery won't show the main effect right away, but in the long run, then we can see the difference, and that's what's really important. So when you look into the protocol for working with ED, I have this model that I've been trying to set up to make it simple. So the strength is motivation for change, support from partner. That's pretty important. It doesn't matter that they come in and they want to have the treatments. If the partner is not interested, then you're going to do a few treatments. They're going to have a disagreement and they're going to stop. What kind of lifestyle factors should they keep doing? They shouldn't be smoking, reducing alcohol. If they're process oriented and patient, this is not from 1 to 1 day. It takes time. They need to remember that. Some of the weaknesses or the challenges is how long they've been having it. If they've been having ED for 5, 10 years, you're not going to resolve it in 2 or 3 weeks. And I've been seeing some of these guys where they come in and expect that they need to see a change in 2, 3 sessions within 2 weeks. And I'm like, that's not going to happen. You've been having this for 2 years. Are there any impact from medications, beta blockers, blood pressure modifications? Are there any comorbidities, especially diabetes, severe depression, stress, cardiovascular disease, atherosclerosis? Do they need to do more physical activity? Do they actually have the capacity of doing that? The opportunities is if they change the lifestyle, we can enhance the functions, we can reduce the PD5 use, they can start responding again, then we can start modulating. Of course, it will give a high quality of life. And then there's all the things out of control. How old are they? If you have guys in the 70s or 80s or even 90s, of course, it's going to be more difficult because the body is not responding in the same tempo. Lack of motivation. It's like, this is your ED now. It's not my problem. You're going to fix it. If they want a quick fix, if they want to feel it right away, I need to feel change from session to session. That is a big no-go. Don't treat them. It's just going to be a problem. And then external factors beyond control, losing job, people dying around them. All these things can be an issue. When we look at what to expect, the PD5 reduction or completely stop, we can get a 1-level progression per treatment course. So if they have a severe, don't expect them to go from severe to being an 18-year-old stop. That's not going to happen. Maybe 1 to 2 levels in general, but then build it over time. We can't do magic. They need to take charge of the health. It's not our problem. Do an evaluation 3 months after the initial session, then you have a good idea about what results they will be getting. The protocol from Elevation is that we do around 5,000 pulses, 3,000 to the corpus cavernosus, as you can see on the screen, and then we do 2,000 to the crura. Remember, the penis is more than what you can see, so we also need to work with the pelvic floor. If you stimulate the bulbous cavernosus muscle, the pelvic floor muscles in general, you're going to get some quite good results because that's also a part of maintaining the erections. The standard treatment is 4 to 6, once twice per week, depending on the severity. So for me, light degree will be around 6 treatments, severe degree 12 at least, and also depending on the lifestyle. So this is a guideline. You can work in different ways. You don't need to limit by that. You can work with different intensities. Some people want to be able to feel more. Other people, they just want to feel the tingling. In general, remember, it doesn't hurt. The biggest red flag is if there's a high PSA, if there's the suspicion of prostatic cancer, then you don't work over the prostate. Although with this linear source, you're only gonna get the energy into a few centimeters. So if you work in the crura or you work on the penis, you won't be able to affect the prostate from the theoretical point. But of course, you also always need to have a safety precaution. If something is not working as you suspect, then this is also from the EAU guideline. Then you can assess again, you can do a retrial, you can do the treatment one more time, you can see if you should combine anything. And that is where I work in a different way. I put everything into the box from the beginning. So if I know that I need to combine shockwave with magnetics to stimulate the nervous system more generally, because it's a diabetic, then I do that. I'm not going to do 6 sessions. Say, okay, this didn't work. Now we're going to do something else. Remember, we're not doing research. We're doing a change for the clients standing in the clinic. So it's quite important to be honest about that and not just drag it out. So I have a lot of things. I have the shockwave, I have the magnetics, I have the lifestyle changes. For the severe ones, I also use a vacuum device. I adjust the sexual activity. So it's really about figuring out what is the need of the client. This is some of the data I have in the clinic. Um, and in general, I see that within the first 6 months, they're going to have an improvement. Then some of them will fall a bit down. And again, the numbers can manipulate the progress a bit. Why the severe one in this case is dropping after 12 weeks to 25 and then have an increase. Maybe it's because not many is capable of doing the follow-up after 1 year. But the general tendency is that we have an increase in the function the first 6 to 12 months. Some people, they will have a lasting effect for 1 to 2 years. The last few months, I've been having quite a lot of clients coming in after 4 or 5 years from the previous course. Now they want a retouch. They want to have a new treatment course. Then we do that. In general, I now recommend to do regular maintenance, just like females is going to have the leg racks. This is one of the cases, a male that was 70 years old. He was having a bit of obesity. He didn't have a high score, and you can see just in 12 weeks, we actually go from a 8 to a 19 point, and that's a quite significant change. So the reason why we have so good result with him is that he reduced the alcohol. He started exercising more. He built his self-confidence. We did 12 sessions on him, but it's a combination. So we take all the factors that can affect the system in general, we enhance the functions. So this is one of the unicorn cases where you go from basically the 70 to the almost 18. This version of the IF5 is only going to 25 points, so that's quite good. But just remember, not everyone would look like that. The Adams score is a way to see if there's potential androgen deficiency. We didn't talk about that because we don't have the time. But just look at the increase in 3 months because he's starting to do the exercise. He's changing his lifestyle. So that's really, really important. So when we look at that, we really need to go in and say what is realistic. Um, so if we go to Peronis, I'm going to take all the questions in the end. Um, One of the most important thing is that it's very debated in urology how we should use shockwave or not. But in the active phase, they actually put shockwave as a part as the pain control. But we also need to look into why and how is the structures affected. So these pictures is from my own clients, and you can really see there's a big difference in the presentation of plaque. You can see the very big pieces of plaque. You can see swelling of the Bell's fascia, the tunica. You can see fibrotic changes in the septum of the penis. That is a middle picture in the lower part. different vectors, and that also requires you a more specific treatment that's going to be tailored. You can also see that in just 2 weeks, you can get new plaque. So this is a guy that's been receiving PRP injections in another clinic. It didn't give the effect. The evidence is not that good for that right now. He wants to have a new scan. I did it. And then we did a scan 2 weeks after, and I could see there was a new plaque. So when you work with these, it's really important that you also do a scan, you keep monitoring it because it can be development, and we call it more a progressive disease right now. And that is because of inflammation. A lot of the reasons why we get the peyronie's is because of smoking, trauma, alcohol. It's lifestyle related, so diabetes, hypertension, dyslipidemia, obesity. There's all the also the genetics, the tryptophan contracture, aging, testosterone. So we have a lot of things playing a role. So when we look at it, inflammation, oxidative stress, immune response is one of the big things, but that is also some of the factors we can work with Shockwave when we look at the basic research. The data is conflicting. I will admit to that. This one say that it fails to improve the curvature and the pain, but it can maybe reduce the plaque size. And when we look at the basic research for Shockwave, we know that pain is one of the most simple things we can modulate. Other studies will say that we cannot reduce the plaque, but we can work with the pain. This is also because of conflicting protocols and, in my opinion, a bit too conservative. This shows that if you have uncontrolled diabetes, then you have a higher risk of having severe plaque formation. So again, we're back to the lifestyle part that we need to control it, be sure that we have the baseline working, because then we can also get better results with implying the shockwave for enhancing the biological effects. This is a study from Denmark, Lars Lund. I know him quite well, really good guy. He did a study where he combined focal shockwave with a vacuum device for Peyronie's. And you can see a difference of about 14 degrees between the active and the control group. The reason why it's not significant is because the dropout of one client, but you can see an increase in the erectile function. You can see a decrease in the curvature, but you're going to have a better effect if you also start working with multimodality. This one is showing different options for Peyronie's disease, and it basically puts shockwave quite low when we look at the erectile function. But if you combine it with a traction device, then you get a better function compared to either shockwave or the traction alone. So again, we need to look into working 360 around the client. Then we're gonna get the better results. This is a case I did when I got the device in the first place, a G4. We did a medium intensity. Normally I would go a bit higher. 10 sessions, 0.47 millijoules. I also combined with magnetics. We went from a 45 to 60 degree to about 30 to 40 degree. You can see that the plaque size is reduced to about 50%. The plaque was, when we palpated it, feeling a bit softer. The guy was extremely happy. Basically, this saved his sex life. So he invited me for his birthday and introduced me to his wife and friends and told about how awesome this was, because it's really been a big problem for them. The protocol is right now about 3,000 pulses if you look at the standard protocols. But if we have scattered plaque, if we have many pieces of plaque, then it will be 3,000 pulses per plaque. If it's more in the tunica, then I wouldn't use the point focal as displayed here. I would use the linear, because then I can hit a bigger area of the plaque, because that can be several centimeters long. So then I want to have a more general application. So again, you need to do the scan. You need to, again, do the scan, because otherwise you can't see what it is. One thing is that you can feel it, but that can be something completely different compared to what you see. So it's important to see what you're actually working with. Then you define the depth of the energy. That's also why we have all the different standards for the elevation device. That means that you can basically deliver the energy with a 5 millimeter interval. So you can be extremely precise, and that's what we need with Peyronie's disease. If we're gonna go to the chronic pelvic pain before we're gonna go to questions, then this is very complex. And When you have clients, they will be seeing the urologist. They will have been in the system for maybe 1 or 2 years. They've been having all the tests, but they still have pain. And this study is quite interesting because it shows that it should be a multidisciplinary approach, but also multimodal. So when you look at the options, we want to try to avoid the surgery. We're gonna support them with the mental part, cognitive behavioral therapy. We can do the medication; they're most likely already on that, and then we can do myofascial therapy, and that is also where we have the shockwave coming in. This is most likely the only area where I would use the radial shockwave, because then we work with the muscle. If we work on the prostate or the bladder, I would only use the focal device. So we need to work 360 around it to have a good effect. And just remember the basic anatomy. We have the muscles. Again, try to keep it simple because that is where a lot of the clients they have been falling behind between the chairs is because they don't look at the simple explanation at the first. But dental nerve is a big part of it, and the muscles surrounding it. Is it gliding? Is there good mobility? Are there very tense muscle? Are they very weak? If the muscle is not functioning correctly in the pelvic floor, that can give a lot of the problems. But that is the last thing these people will be examined for. One of the studies that Johannes Müller has been doing, that I know quite well, and we've been talking about this study sometimes, is that you can find the trigger points with the elevation device. So you can be very specific to locate the referred pain, and that's something you can use when you try to identify the specific pain points in chronic pelvic pain, because you can go in, find the point. When you find it, then you stay in it until the pain resolves or the trigger point resolves. So when I've been talking with different urologists and they discuss the pelvic pain, they do palpation, they try to find the trigger point, they see it as a musculoskeletal disorder. So try to look into that part as well. When we look at the evidence, then this study shows for chronic pelvic pain that we have a significant decrease in pain and symptoms in general when we do the shockwave treatment. This is done with 6 sessions. The next thing is that there's no significant difference between 6 and 12 sessions when we look at chronic prostatitis and chronic pelvic pain. They see we have the improvement in urinary symptoms, erectile dysfunction, quality of life. That doesn't respond to other treatments. One thing we need to take into consideration is that if these people has been having pain for several years, maybe they're not going to have a significant difference between the 6 and 12 sessions. But from the mental perspective, they need the support. Or if they also have the severe ED, maybe they need to have a bit more than the 6. So again, see the protocols as guidelines. Look into the client and their needs, because that will make the difference when you're going to do the treatments. This study is also quite interesting, also just looking into pelvic pain as a trigger point problem. So 6 sessions, 6,000 pulses, different areas. Maybe you're not going to do 6,000, but you're going to work with point 1 and 2 the first session. Then the pain will move more to 4 and 5 on the next. Then you do that, it's going to be 3, then 1 or 2, it will move a bit around. But you can work from session to session, different areas. I don't do 1200 shockwave if I can do only 500 and I have the problem solved. So again, it's a guideline. Work with your clinical reasoning and the experience you have, and then combine it with the protocols and studies. The treatment protocol here is depending on where you want to go. About 8,000 pulses for chronic prostatitis. You're going to have a specific applicator. You're going to find the depth. Again, energy, we haven't talked that much about that, but again, we adjust it to the specific client. We don't say, okay, I need to be on 0.15 if the client is screaming at 0.1. So we want them to feel it, but it shouldn't be pushing them over the limits. So use it easy, start low, and then build it. We don't need to go that high to work with pain or inflammation. So the take home before we're going to go to the questions. If you want to have Shockwave as a part of your clinic, then this is the way how I set it up. You need to work with education, process-oriented patients, both for you and the patient. What are the motivation for change, quick fix, lifestyle changes? So talk about it. Talk about what the options is for the device. When it comes to the protocols, it's guidelines, it's recommendations. I always base it for the client. I never just say, okay, this is the absolute standard. We need to adapt it. Look into the severity of problem, impact from medication, frequency, once or twice a week. But I also have clients traveling in that's getting 4 or 5 sessions in a week in a row. Then they get a long break and then they come back because we want to supercharge. It can be people coming from Finland or Spain. The investment, there's both the one from you for the device, the different applicators. The more applicators you have, the more therapy sources, the more specific you can be, and the more wide range of treatment you can do, both in musculoskeletal, but also in the mental health urology. The client, of course, invests some money, but they also invest the time. So they also demand results. So that's also why the education is important, because you need to set expectation and say, what can we actually achieve with the intervention we're going to do for you, and what do you need to do? When it comes to the clinic, you need to look at this as a long-term mindset. Um, this is a long-time investment. The first few months, you maybe not going to see the return of investment. Um, Sales rep will always say, of course, you're going to have it paid off in a year. You can also have that if you have a really big setup anyway. But look ahead. You don't need to do erectile dysfunction, peyronie's disease, pelvic pain, complex incontinence in the first month. Start one step at a time. Start with erectile dysfunction. That's where you're going to have the most clients. Then go to the peyronie's, or go to the pelvic pain, then peyronie's. If you don't have the ultrasound, then you get the ultrasound, work with the peyronie's. So set a strategy. I set a strategy back in 2020 that I wanted to go from a mix of musculoskeletal and men's health to just working in men's health. Today, I basically only work in men's health. The only musculoskeletal cases I have is if one of them is having a back pain or plantar fasciitis, then I do that as well. Or if my friends and family is having issues. So it takes a while before you go to that point. Just remember, it takes time. And the most important thing is it's a part of your toolbox. Just like PD5, injections, magnetics, put in your secret sauce, what you have of special thing that is just the unique part of your clinic. So Shockwave would be a part of that. It's not always the only solution. Remember that there's also other options that you can combine. If you do that, you're gonna have happy clients and you're gonna have a good clinic. So with that, I will go through the questions. I'm gonna stop the sharing of the screen just so I can see what you actually been asking. So when we look at the first one, radial pressure wave have a role in the treatment of urology? No, definitely not. Not for Peyronie's disease, not for erectile dysfunction. As I said, you can use it in pelvic pain. There can be reasons to do that because it's more the muscle tissue. I know there's some marketing concepts talking about the radial pressure wave, but as you also could see in the study, it's going to be a very short-term effect. So it depends on what you want. If you just want to have people coming in for many, many months having radial treatment, yeah, you can do that. But in the long run, it's not going to change very much. Then there's a question about vasogenic erectile dysfunction. Currently, many young men, have ED due to stress. And is Shockwave effective for these young individuals? That is a very good question, and it's very complex. The way I work is that I also do the sexology part, so I do a narrative talkative therapy. So you can definitely work with young guys that having stress with Shockwave, but then you need to work with the right point. So for me, I work with magnetics to calm down the nervous system. But what you can do with Shockwave alone is that you can work on the sacral area. You can work on the spine for where you have the nerve roots going out into the pelvic floor. That can stimulate a bit of activity, so they regain the awareness from the body that they have that area. That will be guys that not having their morning erections anymore. But you also need to look into if there's a lot of stress involved and performance anxiety. So if we just take it from the clinical physical perspective, yeah, you can use it for the young guys if it's a stress related, but you need to regulate the stress. Then you can talk with them during the shockwave sessions. Then it will act a bit like placebo. You talk them down. Why is it you have this issue, and that can be a factor. Um, so it's a bit of a mix. Maybe you need to have more tools in your toolbox. And there's a question about how confident are we that these changes and improvements are from shockwave itself and not the change from lifestyle exercises. With the shockwave studies, that is done with shockwave alone. So we know that we have this biological change. We also know that if you do stem cells for the top 5 soccer players in the world, they will be responding completely insane for that, for tendon and for other conditions. If we do it for the average Joe, maybe not that much. So it's also about that if you have a healthy environment in your body, you're going to respond better to the inputs that you put in, no matter if it's medication, shockwave, exercise, pills, and etc. So I wouldn't look very much to like this is the only solution. That's also why I seen a lot of failures, especially for diabetic patients, that if we just do the shockwave and we don't treat the cause or some of the additional factors, we're not going to have the same success. So, of course, it will be a combination of several tools and factors. Um, but we know from basic research and all the clinical trials that there is improvements by shockwave alone or from PD5 alone. But when you start combining these things, then you're going to have better results. So if I take my diabetics, that doesn't change anything. Yeah, they get a small improvement, but as soon as they start working with the disease, then it's going to be better. Um, about the additional treatment sessions for diabetics patients, yeah, I start with 12 sessions always because it's both the vascular part, but it's also the neurogenic part that we need to address. Then we have a question about beginning a prostate hypertension case. Yeah, for ED with magnetics, I do magnetics and and shockwave in the same sessions. Um, the shockwave will not make the prostate have the same size. It won't make it grow. It won't make it smaller, but it will help with some of the symptoms. So you can modulate the quality of life within that. Um, and that's what we need to remember. What are we trying to achieve with these sessions? Is it a cure? Is it relief of symptom? Is it improvement of function? There's something, these are out of control, and we cannot control how the prostate is working or expanding, but we can control the nerves around it. We can control the function so it still remains flexible. So you can use it, but it's not something that's gonna make it disappear. In general, and I think that's very important to remember that shockwave, if you do 2, 3, 6,000 pulses, that is not a big treatment compared to a lot of other things. So you can easily combine. And the biggest sessions I've been doing has been up to 10, 12,000 pulses of shockwave combined with magnetics, same day. Just be aware that the tissue can be a bit tired. They need to have a bit of relaxation unless you, as I said, have these very intense sessions to supercharge the tissue, and then you know that you need to compensate. So you can easily do it in the same day. Regarding the shockwave to start the treatment course after radical prostatectomy, right now they say when PSA is dropping to 0. Now we're debating if it's around 1, is it dangerous? So the study I showed you started 1 to 2 weeks after the surgery. So basically, as soon as it's possible, we're going to start working on it. And that is because we want to have reduction of the scar tissue. We want to re-innervate the nerve. We want to increase the blood flow. We want to have all these growth factors going in. So 1 to 2 weeks after, when cleared by a urologist, then you can start. Otherwise, most people will come 2, 3 to 6 months after the surgery. At least they need to have the catheter removed before we start treating. And the protocol will be working around the penis, working in the pelvic floor, putting in vacuum devices to make sure that they get the erections, work with physical therapy. Um, so we should be able to do that good. Are there any last questions? Otherwise, I will round up. So 30 seconds to put in the last one. Otherwise, I will say thank you to you guys for listening in. Thank you for Yes Group and Elevation Medical for making this possible. Any last questions? So the take home is there's a lot of options with Shockwave. You need to understand the technology, read into it so you're sure that you know what you're doing. Always combine with modification of lifestyle. That will be the secret sauce. And just play around, have fun. Remember to try everything on yourself so you know how it feels. No further questions. So I'll wish you a very nice evening, and we conclude the session from here.